I'd like to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And each of you throughout this province and Turtle Island are coming from your respective territories, vowing very much to learn more and be respectful of the places that we have the privilege of being. Next slide. So it really gives me great pleasure to introduce Dr. Navdeep Tangri. Nav is an attending physician and associate professor in the Division of Nephrology in the Department of Medicine and the Department of Community Health Sciences at University of Manitoba. He's really done an amazing amount of work in really trying to do clinical and translational research focused on improving clinical decision-making for people living with chronic kidney diseases and those at risk for it. He's developed and validated the kidney failure risk equation, which you all know and love, known as the KFRE, for those of you that use it, which is the gold standard to predict the need for dialysis in patients with kidney disease. He's been leading several efforts to implement the risk prediction across the spectrum of kidney care, and is the PI on a large multi-center randomized trial in the CKD population, working with primary care as well as with specialists both across the country and internationally. Now, it really gives me great pleasure to be able to introduce you and to see where we've come and where we're going with predicting outcomes. So over to you, please.
Thank you so much. I'm happy to share my first slide and try to present, hopefully, a lot of new content. So the nice thing is that some of this content, not all of this content is mine. It's always nice when you get to present some content for others, and at least a chunk of the content I present today will be from my colleague, collaborator, and friend, Dr. Manish Sood. Some of the content wouldn't be possible without our cross-Canada collaborations on the data side with Pietro Rabbani as well. So I want to acknowledge Manish and Pietro for their help, and of course also acknowledge that I'm speaking from Winnipeg, Manitoba, which is Treaty 1 land, and I think home to the Ojibwe and Métis people. So these are my disclosures. So I want to put together a provocative set of first two slides to set the stage for this talk. And that's my vision for risk-based care. And I think that what you're going to see in the next 40 minutes really takes forward from this vision. And this is sort of how I think about kidney disease. And, you know, I think we're a long, long way from there yet. And that's why I urge you to think about these two slides throughout the talk, and hopefully we can even have agreement or disagreement on them in the question period. So the way I think about kidney disease is, first, can we predict who will develop CKD? And the reason we need to do this is because population-based screening for CKD is not recommended. It's not recommended in Canada, it's not recommended in the US, it's found not to be cost-effective. But if we could predict who will develop CKD with a good degree of certainty, we can screen those individuals at high risk earlier. And if we can, maybe we can treat them with RAS inhibitors first if they have hypertension. So if you have two people with hypertension, one who's high risk for developing CKD, one who's not, maybe the high risk person gets a RAS inhibitor first instead of amlodipine or a beta blocker or a diuretic. Then if they're diabetic and they're at high risk for developing chronic kidney disease, maybe they get metformin, then an SGLT2 inhibitor instead of metformin and a DPP4, metformin and a GLP-1. Just a thought. So now let's say you have a number of patients who have chronic kidney disease, but they're very early in their course. So who will progress? And by progression, I mean 40% decline in eGFR, which is the outcome accepted by the FDA. If you have it, you have a 10-fold higher risk of dialysis, 6-fold higher risk of death, and a 2.5-fold higher risk of hospitalization downstream. So if we can find these patients early, maybe they get triple therapy. And this is kind of borrowing from the heart failure literature, where everyone gets RAS inhibitor, SGLT2 inhibitor, MRA, and ARNI. And you know, for CKD, we now have triple therapy. So potentially these high-risk patients who are going to have a 40% decline in GFR can get triple therapy to prevent CKD progression. Not delay CKD progression, prevent it over a lifetime. You can follow them more closely. You can initiate statin CV risk reduction earlier. Once someone has later stages of CKD, can we predict who will progress to dialysis? We can, using the KFRE, and we should refer them to a nephrologist. Those who will progress to dialysis need to see a nephrologist. They need counseling, education about preemptive transplant, access, home modalities, and some of them need interdisciplinary care. And finally, within patients who are seen by a nephrologist, can we predict who will do well on dialysis? I think if we can counsel patients appropriately and actually personalize shared decision-making and not show everyone the same decision aid about transplant, home dialysis, PD, and so on. And if we can, maybe we offer them a catheter instead of a fistula, for some patients who are at very high risk of short-term mortality. And why do we need to do all of these things? Because there's a complete mismatch between CKD prevalence and awareness, okay? So this is data from NHANES. So if you look at the CKD seen by nephrologists, it's mostly here in that 0.5% out of 14.5. The CKD that's actually there, 14.4 out of 14.9, is in CKD stage 1 to 3. You superimpose this on awareness, there is little awareness of CKD, even in patients who are high risk. So in CKD stages 1, 2, and 3, these are people who have albuminuria, and in this case, albuminuria and a diminished GFR. Awareness is extremely low. And the whole premise behind the next 40 minutes and my entire research program is based on this slide. CKD stages 1 to 3 are asymptomatic. Detection requires active screening in at-risk asymptomatic individuals. The diagnosis typically occurs at CKD stage 4. When we're that late, there are few opportunities to delay further progression and avoid complications. Across the board, in Canada, the US, the UK, patients are referred to a nephrologist at a GFR of about 35 to 40 mils per minute at most, somewhere between 30 and 40, with an average of 35. How narrow is the therapeutic window to initiate the RAS inhibitor, the SGLT2 inhibitor, the MRA, when the GFR is 35 at the first time you see the patient? How much time is there really left? Can you only delay dialysis? Is the window for prevention completely gone? And I think, for me, that realization that if we are to actually prevent dialysis for a patient's lifetime, we have to act early, has driven this entire line of work. So the first model I'm going to present is called PREDICT-CKD. It's a project led by Dr. Sood, and I've been, very happy to be a part of it, and we worked together on several of these models. So the first model Manish wanted to work on was to develop a prediction tool for use by the general public, and then a second model called the KDRE used by healthcare providers. And what we're trying to do is predict who's going to develop an eGFR less than 60 in those with a normal eGFR today. CKD screening, why do we want to do this? Well, CKD screen care is suboptimal, right? So this is the best possible data. And, even in the best possible data from SIPSN and other networks, teaching family physician clinics, ACR measurement is 64% at most. I would say this is 40% nationally, 17 to 10% or less in patients without diabetes. RAS inhibitor use, this is the most optimistic estimate in people with albuminuria. I would say the real number is somewhere between 40 to 60. Statin use is about 40% in CKD. So CKD care is suboptimal. The question is, can you develop a prediction instrument that patients can use to self-identify for CKD screening, to improve the awareness of CKD, and to target screening towards individuals who are actually going to develop the disease? So the data for this came from the Canadian Census Health Survey. So this is a periodic federal cross-sectional survey that collects data on health status, healthcare utilization, and health determinants. 100,000 people, and the focus here was really on lifestyle factors, not lab tests, only data that the patient can self-enter. So we included links data to ICES, included patients with at least 2 eGFR measures to confirm that the eGFRs had to be 70 or kind of greater than 90. So the patients were clearly CKD free at baseline. A long list of candidate predictors, anything from comorbid conditions. There was a model with GFR. I'll present to you a model without baseline eGFR because patients often don't know what their GFR is. And mostly lifestyle factors. lots of splines and knots and so on, but this can all be dealt in the background. So two models with or without baseline GFR. I'm going to show you the data that doesn't require any lab values, that only is purely patients entering data. Okay, so here are the results. So mean age 55, mean GFR 95 at the beginning. So these are people who are truly CKD disease free. Only 30% of them have hypertension, 12% of diabetes, lots of them report stress. And the outcome is, GFR less than 60. Okay, so here's the final model. So I'm going to show you the model without eGFR. So it includes age, smoking status, alcohol, physical activity, fruit and vegetable intake, immigration status, education, ethnicity, diabetes, diabetes length, all, do you have heart disease? Do you have high blood pressure? All of these questions. How much do you weigh? And then interaction with age and these variables. The final model has a C-stat of 0.81 to 0.84 without baseline eGFR. And this is whether the outcome is 1 GFR less than 60 or 2 eGFRs less than 60. Now, here's the interesting thing, okay? So overall in the population, only 8 to 10% of people develop CKD during the follow-up period. But look at this threshold, look at these two groups. In these two groups, 15 to 25% of the patients developed chronic kidney disease during the period. So if one wanted to flag patients to self-identify, you could set the threshold at about 10%. And you could say that if your risk is more than 10% of developing kidney disease, go get your urine checked for albuminuria. It's a cheap test, should be done, and your yield in that group would be about 20%. 1 out of 5 albuminiurias would be positive. So I think that that's a useful way to target screening rather than screening everybody, which includes all these very low risk group where the likelihood of developing chronic or having a positive test is less than 5% and even less than 2% in the bottom half of the population. So Manish and I would conclude that incident CKD is highly predictable and it can be successfully developed using a lifestyle-based model without knowing your eGFR. And there's an external validation performed in the UK Biobank, and this manuscript is currently under review. Now, can you do better if you're a physician and you have access to routinely collected existing administrative data? So Manish looked at all adults in Ontario from 2008 to 2017. He looked at adults greater than 66 because he wanted medication data, but then we validated this in Manitoba in all adults across all ages. Again, you had to have normal kidney function to enter the study at the beginning, and the outcome was a single eGFR less than 60, single GFR less than 60, and then also 2 eGFRs less than 60 and also 1 less than 45. Initially started with 47 variables, but really tried to get down to about 6 to 8 variables that were easily collected, easily testable at the bedside. So time to event models. Okay, older adults initially, so mean age 74, mean GFR 82, very low ACR at baseline, so truly disease-free. And the outcome again, 20%, so 1 in 5 developed chronic kidney disease. And the same final model, whether you had ACR or no ACR. So the model includes, GFR, your GFR today, which your doctor would know, age, sex, your hemoglobin, your time, how many years have you had high blood pressure, how many years have you had diabetes, okay? And there's a model with ACR and a model without ACR. And the models are accurate. At 5 years, C statistics are 74 to 78, whether you want to define it as eGFR less than 60, 1 measure, 2 measures, or an eGFR less than 45. Again, focus on this ACR model because these people, this is a physician test using this test, so an ACR should be available. And again, you can see a graded a straight line, kind of straight down the diagonal. You can set it anywhere here where these people, anywhere maybe 10 to 20% risk or higher, should get differential treatment. Again, so the KDRE is a CKD prediction model, 6 or 7 variables, clinically flexible. Discrimination, 5-year C-stat 0.77 to 5.8, well calibrated and externally validated in Manitoba. And together with Manish, we're doing a web host, an online calculator, and coupling it with education and information, targeting the lay public, really trying to focus on, this kind of concept of, especially for the lifestyle one, to try to get who's going to progress, who's going to develop kidney disease, can you self-identify, and can you present for albuminuria screening, because we know today the rates of albuminuria screening are very low. So the next question, who will progress to dialysis if they already have CKD stage 3 to 5? So the answer here, sort of lies in the kidney failure risk equation. Recall, their lab-based equation, age, sex, GFR, and ACR, validated in more than 30 countries, 1 million individuals, and used by more than 50,000 physicians worldwide. I want to just spend some time just sharing some updates on the KFRE, just showing you some data from the last 24 months, which you may not have been aware of. First, the KFREs are now part of the UK NICE CKD guidance. So all across the UK, they're part of clinical practice guidelines and are the key criteria for referral to nephrology in the UK. And as such, they'll be incorporated in all UK EMRs. The second thing is a feature we put on the website on kidneyfailurerisk.com, which can take a patient's current risk and show them how the risk declines with achieving good blood pressure control, ACE inhibitor or ARB, and an SGLT2 inhibitor, and how the benefit of these changes can add up over time. So let's go into the updates. So first, an update from the UK, which is this primary care study led by Rupert Major, which showed the kidney failure risk equation in the UK primary care data set and external validation of clinical impact. So these investigators found that the KFRE is largely accurate in the UK, and they found that a 5% risk of dialysis or an ACR of 70 would reduce the number of referrals to nephrology, but actually catch more people who will progress to dialysis. So the initial NICE criteria were eGFR, less than 30 or ACR more than 60. And if you set it to KFRE greater than 5 or ACR greater than 70, you have more sensitivity, more specificity, less referrals, you miss less dialysis, younger people get referred, and at a higher GFR, but also at a higher ACR. So this is what led to the NICE CKD guidance. I wanted to show this, that I think a KFRE greater than 5 is a pretty reasonable criteria for referral if you have backstops with eGFR less than 30 or ACR greater than 70 in place. The second question that always comes up is, do nephrologists outperform equations? Okay, well, the answer is yes, they do. And this is a study from Dina Rifkin and colleagues at University of California, San Diego. So these investigators compared the performance of the KFRE in their patient population compared to the actual nephrologist prediction as well as the patient's predictions. Now on this slide, you'll see the prediction from the actual event rate of dialysis on the y-axis and the different predictions on the x-axis. So first, on the panel A, you see the dialysis rate and the KFRE, and you actually see a nearly perfect diagonal line, which means the KFRE is highly accurate and really lines up with what truly happens in this nephrology population. Now let's look at what nephrologists predict. So these are nephrologists who actually are looking after these patients for several years, and they consistently over-predict the risk of dialysis. So compared to what actually happened, the nephrologists, would have guessed 60% when the patient actually had a risk of 30%. And I would say across the board, there was really almost a twofold higher risk predicted by the nephrologist than what actually happened. The patients, unfortunately, were all over the place as well, less reliable than the physicians, and certainly less reliable than the equation, almost certainly more pessimistic, across the board. So for example, for patients that had almost a null event rate, the patients almost thought it was 20 to 30% across the board. So I think these findings and others have shown similar results, really suggest that using an equation like the KFRE in the nephrology practice can be a really useful decision aid, and we cannot rely on our gestalt alone, because gestalt and numeracy don't always agree, and it's difficult for us. We know who's high risk, we know who's low risk, but to actually attach a probability to an individual is very difficult. The second question is, can I use the KFRE in transplant recipients? And this has come up sometimes. And I wanted to share two studies on this regard. This is a US study showing that that C statistics for the KFRE at 5 years out were about 0.77 at about 5 years out, slightly lower than in the non-transplant population, but still quite reasonable. There's a very similar study in Ottawa that showed nearly identical results. So I think it's not going to be as good as very transplant-specific tools, but if the KFRE is implemented in your electronic health record or in the lab information system, it can still help you for those transplant patients with an eGFR less than 60 to try and plan for either their next transplant or their dialysis planning. The next question is the KFRE accurate in children? And this was a study led by Erica Winicki and Elaine Koo. This looked at the performance of the KFRE in adolescents. So from the CKID study. So CKID is a well-known study of children and adolescents with chronic kidney disease. And this study found using the 4-variable and the 8-variable equations, they were highly accurate at 5 years across the board in children. So children and young adults, if they have a GFR less than 60, using the pediatric formulas, you can use the KFRE and be fairly confident that you're predicting accurately in your children and adolescents. Before I go to the next piece, there's a couple of slides that I've missed here, which I do want to mention verbally. So I think we're all going to see a change to new non-race-based equations for eGFR. And the question has come up whether the new equations will impact the performance of the KFRE. And now there's at least 2 studies, one from the VA and one from another US health system from UCSF, which have shown that predictions are no different or slightly better for Blacks and non-Blacks when using the new eGFR equations. So when we do switch, and I hope we switch in BC and in Manitoba and across the board this year, that you could be assured that the predictions you get from the KFRE will be just as accurate. So the next piece of data comes from Alberta, and I want to highlight two papers from Michelle, Helen, and Brenda that have really been instrumental in the qualitative evaluation of integration of the KFRE into care. So I think the quantitative data is really important. It's important to know that the equation is accurate, that you can rely on the prediction, but it's probably just as important to see how patients and providers perceive integration of risk into workflow. So the first paper looked at the perceived challenges. So there will probably be some benefits if you implement the KFRE in your clinic. You can focus your resources better. You can have more sustainability of the clinic, so the clinic just doesn't balloon and balloon, and you could perhaps reduce patient stress, okay? The harms could be that some patients are going to lose access to nurse care management, and in fact, those patients who are lower risk but still have CKD will have shorter duration of their appointments and sort of less intensive care, okay? And then whenever there's a change, you need to communicate that change well with patients and providers. And I think, Michelle, Helen, and Brenda really did a tremendous qualitative evaluation, and I'm going to borrow from their work here. So this is pre-post data, the patient experience before and after KFRE implementation in the clinic. 176 patients participated pre and 237 post. First, I want to say that most of the patients had a very similar experience pre or post implementation. But it is important to note that the only areas where we saw improvement were all post. So post implementation, more patients felt that they were able to get the care they needed. More patients felt that the staff were caring to them, and more patients felt that they received safe care. So if anything, focusing of resources to higher risk patients in the multidisciplinary CKD clinic led to a better patient experience, not a worse one. With respect to staff, it was much more neutral. So, there was no differences in pre or post. To some extent, what happens is that providers are looking after less patients, but they're certainly looking after higher risk patients. So I think the overall workload is probably pretty similar You just have less patients, but you have more work per patient. So you have fewer, quote unquote, easier or lower risk patients. So I would call providers evaluation or the provider satisfaction being essentially unchanged. I want to share two quotes. This is from patients. So first quote says, these are representative quotes I picked out from the papers from Brenda's group. So having that equation and knowing the chances of me going into kidney failure in the next 10 years is extremely low, and this is quite reassuring. This is a quote from a nephrologist. It actually really helps, really reassuring the patient and making sure that they're aware of what their risk is. And I think it paints a really good picture and is a great educational tool. From another patient, I miss talking to the nurses, but I'm glad I don't have to do it because it's difficult for me to get there. I'm not unhappy about not going. So I work in Manitoba, you work in BC. I'm sure we all see patients from across our provinces who travel sometimes hours to come to multidisciplinary care clinics. I think as we transition back from, much more virtual care to a hybrid model, it's probably become quite apparent how much of a burden it is to travel to visits for some patients. And several of my patients have indicated a strong preference to stay virtual. And I think that that shows me that how much work we're putting on some of these very low risk patients who probably didn't need to come in person and see the entire team at every visit. So hopefully, I think, the last few slides kind of summarize, why the KFRE implementation is generally helpful for patients and providers in clinic, and how you can envision the reaction that you would get if you integrate it into your workflow. So now I mentioned that, again, I'm going to be focusing on lots and lots of new data. So the next step we wanted to work on was not dialysis, but who will develop CKD progression. So we realized that the KFREs do not predict progression in earlier stages of CKD. So I'll give you an example, and I'll pick up on this example later on. So think of a 50-year-old male who's got a GFR of 80 today and has albuminuria, which is probably not being tested. So this person is very high risk, is probably going to lose half their kidney function in the next 5 years. So they're going to go from 80 to 40, and at 35 to 40, they'll get a referral to a nephrologist. Okay, but by that time, as I said, the window to act would have been lost. If you use the KFRE in that individual, it'll predict a very low risk of dialysis, which is accurate, but not useful. Because somebody at a GFR of 80, even if they lose kidney function at 10 mils per minute per year, is not going to develop dialysis in 5 years. So you need to predict something else. And I would argue you need to predict 40% decline in GFR or kidney failure. I would also argue that we have always been in favor, right from the beginning of the KFRE work, to use routinely collected lab data. Lab data is incredibly powerful. It's almost always present in patients who are being actively followed, and it's not subject to the biases of how you code, how you define a comorbidity, and we know that coding for CKD and these related diseases is often poor. Finally, we're not interested in biomarkers. They're often difficult to assay, they have impractical costs, and really wanted to develop models for everyone. So I want to present some new models we've developed. These were developed originally in patients from the Manitoba Population Health Repository. We had data on 1.2 million individuals over 10 to 14 years, population-wide coverage, every claim, drug, lab test, and encounter. So we focused on 77,000 individuals with an eGFR greater than 10 and who had urine ACR data. And we took the nearest lab test within 12 months of that GFR. We then externally validated these models in 100,000 patients in Alberta. And we used a random forest, which is a type of a machine model. So it's really important to have external validation for machine models because they tend to overfit. If you just look at them in their own internal data set, they will not generalize, they will overfit and overlearn the data. And when you apply them to a new population, they won't work as well. So external validation is really important. The second question would be, why did we use a random forest? Why didn't we use a logistic regression or a Cox model? So the reason for that is that we used about 10 or 20 lab features. So what we did is we took the eGFR and the ACR, and we took 20 commonly ordered labs around 12 months of that measure. When you use a Cox or logistic regression model, it's very difficult to impute missing data, whereas these random forest models are much more robust to missing data. So if you're going to apply this model in a real world setting, you want to be robust to individual pieces. What if somebody doesn't have a hemoglobin, or they don't have a bicarbonate measure? And that's common. So I want to compare our models to a commercially available model. So there's a company called Renal based out of New York, founded by Steve Koka and Girish Nadkarni at Mount Sinai, and they've also developed a machine learning model. So their C statistic was 0.77, ours was 0.87. They had 1,146 individuals. We had 77,000 in internal validation, 100,000 in external validation. We had 4,000 events. They had 171. And their models require these three biomarkers, TNFR1, TNFR2, and KIM1, and multiple clinical demographic lab test data over time, medication data, and we only require just the 20 pieces of lab data. So really, our models are much more accurate, accessible, and generalizable. And I would say, block out the noise about machine learning, block out the noise about biomarkers, and focus on things that can be implemented and scaled at large. So what was our motivation for developing these models? The motivation was this patient example and the fact that care is not aligned with risk. When we looked at Simpson data, this is from primary care, we looked at 7,384 patients and stratified them by low risk, intermediate risk, and high risk. And I show you achieved blood pressure control, statins, RAS inhibitors, and I could put SGLT2 inhibitors here, I could put albuminuria screening here. Across the board, low-risk patients get no better or no different care than high-risk patients. And that's because risk is unrecognized. It's just not on anyone's radar. And it's important that these high-risk patients get more aggressive care, and I'll show you why. So my favorite patient, my 50-year-old with a GFR of 80, whose high risk is progressing at 5 mils per minute per year. If they're unrecognized, they will be on dialysis at 64. If you put them on a RAS inhibitor and SGLT2 inhibitor, you get them down to 2 mils per minute per year. Now they're on dialysis at 85. So they've gained 21 extra dialysis-free years. You apply that same scenario to a low-risk patient who's got a GFR of 80 and at age of 50, they're progressing at 1 mil per minute per year. You put them on a RAS inhibitor and an SGLT2 inhibitor, they're now going at 0.8 mils per minute per year, and they're not going to be on dialysis in either scenario. You've made no difference to the kidney trajectory of this patient. So I think this is why we need to flag these patients early when their GFR is 80 and not catch them when their GFR is 35 to 40. So the final thought. So, last set of models, really early data, excited about this, and hoping currently doing external validation in another cohort. So what about predicting early mortality on dialysis? So you know about the surprise question. There are multiple registry models that predict mortality on dialysis. I would argue they're completely flawed, okay? They're completely flawed because they only include patients on dialysis. There's a massive selection bias, and usually only after the first 3 months. And when you use things like the surprise question, you're relying on subjective data that's not generalizable. Try explaining the surprise question to a patient, to a doctor, and to different doctors. It's really just not a great way to build a model that can be implemented across a system, across a province. So we wanted to tackle this problem, and here's how we decided to tackle it. We said, take a population at a time when the patient needs to make the decision. So that's before dialysis. You need to study patients before dialysis to try to predict what will happen to them on dialysis. And rely on easily obtainable data and get accurate prediction. So here's our mortality model, okay? So we derived in a pre-dialysis clinic population. Our mean age was 70, our mean GFR was 18. We included age, sex, eGFR, albuminuria, which are our 4 variables that we love, and hemoglobin and CHF. Okay. C statistics 0.79 in external validation, larger external validation ongoing. What this model predicts is death before dialysis or death in the first year of dialysis. Like, will you survive at least 12 months on dialysis? Very good discrimination, and we compared it to previous models for this outcome in the CKD population. Calibration could be improved. It may need to recalibrate calibration to local settings, but it's very capable at identifying a large group of patients, a meaningful group, that has a greater than 50% chance of death before or within the first year of dialysis. You could even set it to predict, more than 70% chance of death, but it's not accurate enough. And none of these models are accurate enough, I want to emphasize, to say definitively to someone, you will not benefit from dialysis, i.e. dialysis is futile. So strong caution for me to use any model to tell a patient that a treatment is futile. That I think that would be wrong. It would be an overreach. But what this can enable you to do is to say that this is the chance, that you will, have a long lifespan on dialysis. Of 100 people like you, only 30 were alive a year after dialysis. And I think that could be helpful for patients when they're making those choices as to what to do. So finally, I think I want to spend the last 5 slides saying, if there's a whole framework and all these models exist and they're easily obtainable, easily calculatable risk based on data that you already have in your EMR or lab system, how do you actually make this come alive? So I've been working on several projects, including one with Roche on enabling risk-based care. And we've tried to create this lab-based application, which takes a patient, and this is a dashboard of a patient, and it looks at their CKD stage, gives you their KFRE risk, and highlights the complications of CKD and the comorbid diagnoses. It shows you, what the KDIGO guidelines recommend for this patient, based on their diabetes status, based on their GFR, based on their ACR. And finally, it generates a clinic note based on the risk, and a report targeted towards the nephrologist, a report targeted towards the GP, and a report targeted towards the patient. I think this is just one step. It's just one way to do this. But really, and this is a standalone application, but the focus from all of us should be, get these tools built into workflow, get them built into lab information systems, get them built into EMRs, make them part of how we deliver care. So we've got lots of time left, but this is actually my last slide. I think accurate risk prediction tools can help patients, help doctors make better treatment decisions. They're not a replacement for a physician, they're a decision aid. And I think you and the tool are better than just you alone or the tool alone. I think the lifestyle models and the KFRE model developed by Dr. Sood can help identify patients who may benefit from CKD screening. I still don't see, even with SGLT2 inhibitors and MRAs available, that screening for asymptomatic healthy individuals is going to become a recommendation. So we need to have some effort to target patients who will actually develop kidney disease. I think our disease progression models are entirely lab-based and can be operationalized easily in labs or EMRs. And finally, the last thing I really want to leave you with is that all models only work when they're integrated in clinical workflow. If they're a part of what you do, they'll help you. If you need to reach out and calculate them at every step, if you need to remember in your busy day to take a bunch of extra steps to do them, it'll be difficult for you to integrate. So with that, I'll stop and take questions.
Thanks, Nav. There are actually a couple of questions to get us started. So I don't know if you can see them. I'll read them so the audience can see them. So Daniel Schwartz is saying that we have a lot of data in BC with reduced GFR and proteinuria in the provincial lab database. It's something called PLIS, or Provincial Lab Information System. Many of these patients will not have an ICD-9 code for CKD ever billed, and many with proteinuria will not have an ACE or an ARB listed in their database. So could we use that, or do you have experience in Manitoba, for example, using that kind of data to identify people with CKD who are undertreated and then empower patients and their PCPs by alerting them? Have you thought?
So that's an excellent question, and it actually is the subject of our CanSolve 2.0 submission from the Manitoba group. The biggest barrier to this is breaking the privacy ceiling. So often all this data is kept under a privacy ceiling in Manitoba, certainly, and I think in Ontario and BC as well. I think we need to convince our politicians and privacy officers that high risk CKD. Now, let's say you set the threshold at, GFR less than 30 or KFRE greater than 10% or 20% over 5 years. You have to show them that this is as bad as having an undetected malignancy. So, and that's the point we're trying to make, is that if you're so high risk, but you have no nephrologist visit, no claim, at minimum, let us send a letter out to the patient and the family physician and say, you have high risk kidney disease. You should see a kidney doctor. Now there may be reasons that may have been that the family physician has spoken to the patient and the patient has said, I don't want to see a kidney doctor. But I suspect that there's a good number of patients where this has just been unrecognized. And I think that we do have the ability to do this, but there is across the board a lack of recognition that progressive or high risk kidney disease is as bad as a malignancy, as bad as a recent MI or so on. So I think that's an excellent point.
And as you're alluding to, I mean, there's also this thing where it's not a malignancy that will kill you in 3 years, it'll kill you in 15 years. And so it'll affect you. And so the threshold, the time horizon makes people feel like it's less urgent, which is also interesting. And also, as you know, 25% of our patients don't have PCPs. But for those that do, I think there really is this kind of strange notion that we're not allowed to tell people things that they ought to know. So before we go on, I just want to say in BC, we've never used race in the equation. So we have nothing to undo, which is great. However, I think we're one of the few provinces that never did use race, and that was practical. Now, one of our transplant fellows has a question. How do you feel about integrating transplant into transplant assessment and referral, these models? And do you feel that there's a role for predictive models in stratifying patients who are unlikely or likely to benefit from transplant?
So it's a really good question. So the way I would think about it is in Manitoba, patients are now only seen preemptively for pre-dialysis for transplant if they exceed a KFRE threshold of 20% over 2 years. So transplant, because of the backlog, they switched to that a few years ago from eGFR. But I think your question is really valuable, and I would argue that what we should do is take a population of patients on dialysis and predict either a death on the wait list or kind of graft failure, a death within 1 year or 2 years or some short time frame after transplant. And that may be a useful tool to try and predict who's going to have very limited benefit from being on the transplant list. I haven't tackled that, but you are welcome to, and I'm happy to help.
How is Manitoba implementing these tools? Like, have you guys worked with your provincial database or others to have this upstream risk stratification?
So upstream is really hard. It's really, upstream is very difficult, an excellent point. I think the first thing we're trying to implement is what Dan's question was, and what Adira had brought up is, through CanSoft 2.0, we're trying to implement basically a safety net. We're trying to catch people who are just very high risk actually and have never seen a nephrologist. That's the first thing we're tackling. I think, to be honest, the market for upstream, the appetite for it is actually higher in the US than it is in Canada to some degree, because US payers are very aware of the costs of CKD and of late stage CKD. So they're actually more interested in finding patients early on, again, but unfortunately for them, they don't have a very long horizon. But they're interested in finding patients who are going to progress in the next couple of years. Like if a payer typically holds, like United, Aetna, will only have a patient typically for about 2.5 years. But if that patient's going to go from CKD1 to CKD4, that's going to become a very costly patient. So they're interested in identifying those patients. Canadians, unfortunately, it's tough.
Are you, in your KCC clinics, are you using it to triage to, for example, as you were stating, less frequent follow-up or less frequent blood work? Or,
Yes.
I think there's also, because I think that's an interesting question. I've always thought, like, at least if you do serial blood work, then you have a totality of 7, you'll identify your AKIs, which may, in fact, maybe that's a question also you can answer, is how does an AKI episode impact the trajectory?
Yeah.
And what would you do? Like, how do you incorporate these episodes into your prediction? Do you redo the predicting equation?
So I think some of it is very difficult because they're unanticipated events which you just can't capture. So that's always about 10 to 15% of patients will be labeled low risk and something bad will happen to them, and it's very difficult. So, but in our KCC, we use it. We have these thresholds. So we use 40% over 2 years to plan to start fistula, like plan for fistula surgery or a definitive PD catheter assessment. 20% over 2 years is our rule for you have to have education by then and you have to have a decision. So like some decision has to be made. And then if those are kind of in that 10 to 20% range people, we see them every 6 months now, but we get labs every 3 months. So that's kind of, we're using it. And then the people who are more than 40%, we get labs every month in those people. So we're using it in combination with GFR thresholds to determine intensity of care.
And that was Kevin Horgan's other question, is informing the timing of vascular access. I know that, I think we certainly have the ability to potentially implement this within the PROMIS database and others, and build in tools that would help alert people. So that would be something interesting to look at, and whether there's an appetite on the part of the clinicians and the team, including the nurses and the dietitians, in terms of intensity of counseling, frequency of education, and follow-up. I think that,
we have been successful with one lab in Ontario to implement routine reporting of KFRE whenever ACR is done. And we actually have good communications with BC Life Labs. And I think Andrew has been, and Dan Schwartz has been helping a lot with those efforts. They did indicate to us that they would consider it when they do any GFR equation updates. So we are going back to them. So any support from the BC EPRA on to Life Labs, would be helpful, I think.
Yeah, well, there's a BC Association of Lab Physicians that actually also helps, because that includes more than Life Labs. That includes all the hospital-based labs and the other labs outside of Life Labs. So that's something that we could certainly speak to. Daniel is on the call. And so I wondered if you want to say anything, but while he's unmuting himself potentially, Kevin's got one more question. Data on improved outcomes when switched KFRE, 20% risk at 2 years threshold.
I don't have a lot of our own data, to be honest. There's all these retrospective studies, but I think Ontario switched to KFRE for a lot of KCC decisions about 4 or 5 years ago. And Amber Molnar is doing a large study pre-post looking at outcomes. So she'll probably have data in about a year.
Great. Daniel, you're unmuted now if you want to comment. Thank you.
Nav and I have been chatting about this problem for, it feels like years, but I think we both believe very strongly that the science is great, but if it doesn't get into the clinician workflow, it's of no value because people won't do it. And so we've also found that collaborating with EMR providers directly is very challenging. They have very little incentive to create better products, and that the best way or the easiest way to get good data into workflow is to actually go through lab providers, because we already have a standard where you can have data which is reported, but also blocks of text. And that's all, there's already an infrastructure to transmit all that data. And so we've been chatting with lots of different people, both in the US and Canada, about how do we take that data that's reported by labs and basically, sideload it into EMRs to achieve some of our clinical interests. And so, as Nav mentioned, we've actually been chatting with Life Labs for a while, and they are a business and they're trying to find a way that they can make money doing this, I think. But I think there's enough motivation to move this forward that I suspect we will see them move this forward.
And I think, yeah, as I said, we can also go to the BC lab. So Andre Matman from Vancouver Coastal Providence is the chair anyways, whatever is one of the chairs of the BC Lab Physicians Association, which is the actual body that includes life labs, but also includes the hospital-based systems as well, because I think it'll be important to make this available, irrespective of where you get your blood work done, because some patients get their blood work done at the hospitals, and you wouldn't want them excluded for various reasons. So, but I think that's great, and it'd be great to see where we can get, because I know that not everyone knows what Simpson is. Nav, do you want to maybe explain that?
Yeah,
Sabrina Wong, Sabrina Wong is here,
So Simpson is the Canadian Primary Care Sentinel Surveillance Network. It's a national network of primary care clinics which feed in data into a central repository from the EMR. So it's like an EMR extraction tool that pulls in data. And Aminu Bello and several others have been working with Simpson on CKD questions. Basically, all of us recognize the reality that most CKD lives in primary care. So we've been trying to we were trying to improve CKD care in primary care offices. So I had a CanSolve 1.0 trial in Simpson. We also integrated dashboards to improve kidney care in the Simpson data presentation tool, which is a tool available to Simpson doctors to visualize their CKD population. So we think it's a great way. It's almost, I think almost like 500,000 patients or more nationally, so it's pretty large. So we're hoping to have more and more of an impact through Simpson right into the clinics.
Yeah, no, I think it's exciting, and it's also a little bit sobering to think about how much data exists in the electronic space and how little of it we actually use in an organized fashion because of our, I'll be a bit our federated model of healthcare, and even within the provinces, it's not coordinated with any one province. So, but I think it's as great. Are there additional questions that people have? I mean, what Nav's presented to us is really a way to use information that for any one individual is in front of you, but in totality, maximized and used with tools that help organize things actually will allow you to make better clinical decisions for individuals and for populations. And I think it's very important for especially the junior physicians and the nurses and others in the audience to appreciate the real value of the systematic evaluation of information that's right in front of you and how best to use it. Any final comments, Nav? Or it's an exciting time, and it's also just sad that it's taken us this long to get to here.
Yeah,
right?
Yeah, I know. Thank you. I think the final comment I would say is if workflow. Keep whatever you want to see. I don't know. Alberta has switched to Epic EMR for their entire province. I don't know which way BC is going to go. I don't know which way Manitoba is going to go. But if you use these tools to see patients, bug your IT people, bug your lab people to say, build this into my workflow. It's technically not challenging. We would estimate, and Dan and I have been, through this, trying to push EMR vendors. We think it's about 15 hours of work, for example, not a lot. So 15 hours of work in total for an EMR vendor to take the code we would give them and put it into the workflow. So it's not a lot, and maybe hospitals also take this on, build it into your workflow. If you build it into workflow, you'll make better decisions.
I mean, there's two problems with hospitals, right? So hospitals are acute, and so the majority of that won't apply. I think that's a big thing. But where there's outpatient, it will. The problem in this province is we have 3 EMRs, Cerner 1, Cerner 2, and Meditech. Yeah. So the 2 Cerners that exist here aren't even the same. And then we've got Meditech, and then the EMRs are different, specialist and primary care. Wow. And I think fundamentally there's a problem in healthcare in that we need one EMR like the UK. Like, it makes no sense that we're doing this. But your point's well taken, and where we can integrate into a consistent EMR or a consistent database, something that helps socialize these tools, I think that would be really important.
Right. Thanks very much for having me.
Yeah, thanks very much, Nav. Thank you everyone for your participation and for listening and for thinking how you can use this going forward.
Yeah.
Okay.
Thank you.
Thank you.